So we'll go through at least the first half of the slide deck. There's 97 slides in the review slide deck. Was everybody able to pull the revised deck off Canvas? The practice questions that are in the review deck have the correct answer in the notes, but not an explanation. So if you don't know why the correct answer is the correct answer, you might want to dig into that a little bit further. Okay. And like I said, this is your 80% solution. So, be able to interpret your analysis results. Know what the various findings on your analysis are indicative of. For example, if you see a UA that has white blood cell casts on it, what is a likely explanation for that? Interstitial nephritis. What else? Pyelonephritis. How would you tell the difference between the two? What would be a presenting characteristic that might be described in the stem of the question that would make you think one versus the other? Flank pain. What else? Fever. So if you have a patient that comes in and they're sick, febrile, nausea, vomiting, flank pain, white cell casts on your analysis, then the likely diagnosis is pyelonephritis, right? Be able to interpret BU and creatinine ratios in GFR. So there are certain situations where the BU and creatinine ratio may be useful in helping you determine what the underlying pathology is for a patient. Know what those differences are. Okay. You need to be able to calculate a fractional excretion of sodium. So know that formula. I'm not going to give you the formula. You got to know it. Okay. Any questions on any of this? Oval fat bodies. I've mentioned oval fat bodies a lot. Good chance you're going to see a question that involves oval fat bodies on the exam. Know the different types of casts. So we talked about white cell casts already, but I highly recommend that you review this chart. It will be helpful. Any questions on any of these casts? All right, so again, fractional excretion of sodium. You know how to calculate it. Know what it means. Be able to differentiate between a pre-renal and post-renal fractional excretion of sodium. Any questions on that? Make sure you know the formula. Okay. Imaging modalities. So you will probably see questions that present you with a patient, and it may ask you what imaging modality should you utilize for this patient, or it may give you the results of an imaging study and say, what does this mean? So a solid enhancing mass on CT scan in the kidney, what is that? Renal cell carcinoma. If you're going to evaluate somebody for hematuria, what are some imaging studies that you can use?
CT and
CT non-con if you suspect a kidney stone, sure. This is not feeding back. Hang on a second. What else? So CT non-con for stones.
Con and non-con for cancer.
So what's the specific one that we use a lot in urology?
Angiogram versus.
So you don't use the CT cystogram to evaluate for hematuria. So CT urogram is the three-phase CT scan that looks at the kidneys, both with a non-con phase and then a vascular phase and then a drainage phase, right? It shows the contrast going down from the collecting system down the ureters to the bladder. You can also use renal ultrasound to evaluate for hematuria, depending on a patient's risk stratification. Electrolytes and acid-base status. So, expect to see questions that provide you with a patient presentation and laboratory values. Normal ranges will be given, okay? But expect to see questions that have pH, bicarb, PaO2, PCO2, and maybe some electrolytes. And it's going to ask you to determine the patient's acid-base status. Is it a metabolic acidosis? Is it a metabolic alkalosis? Respiratory, etc. Okay. Be able to calculate an anion gap. Know the formula for calculating an anion gap. Those are the two formulas that you're going to need to know for the exam. It's fractional excretion of sodium and anion gap. Okay, so make sure you know those. This flow chart will be high yield. You may see this chart in some form in a blue box explanation at the end of a question or more. So if you can work your way through this chart, that would be useful. Any questions about any of this? Remember your effective osmoles and your ineffective osmoles. Knowing what can cause somebody's serum osmolality to be elevated in a given clinical scenario might be useful. Like DKA, for example. You can expect to see several questions on electrolyte imbalances, hypernatremia, hyponatremia. Know the difference in volume status, hypovolemic versus hypervolemic, euvolemic. What is a medication that we talked about that can cause SIADH? It's a psychiatric medication. Lithium, heard somebody say it. Know how to treat hyperkalemia. So what? Well, it's on the slide. First thing you give, for somebody who's hyperkalemic?
Calcium gluconate.
Calcium gluconate. That's probably going to be useful. And again, remember your ineffective osmoles. So if somebody's hyperglycemic, that's probably going to show up on a lab test, right? If they had a metabolic panel checked or a finger stick. But is something like mannitol going to show up on a lab test? No. But you might know that the patient's been given it. So keep that in mind. Remember, hypercalcemia can be a sign of a paraneoplastic syndrome. Be able to calculate an anion gap. Okay. And I would recommend memorizing this chart. Or if one of the other versions of this that we talked about in the acid-base lecture is more useful for you. But knowing what happens to the bicarb, CO2, and the pH in these various conditions will be high yield. And don't just focus on the direction of the arrows. Know that there can be compensation. So you might have a clinical scenario where maybe something is just barely in normal range, but it won't necessarily line up with everything else that you're seeing. Remember that the body can compensate. But know this chart, or some version of it, if one of the other ones is more useful. Like this one. Anion gap. Remember the things that can cause high anion gap. Because there may be something in the stem of a question that should make you think, I should be concerned that this patient might have a high anion gap metabolic acidosis. Know the difference between chloride responsive and chloride unresponsive metabolic alkalosis. Being able to differentiate between the two might be helpful. You'll probably see this chart on the exam. So we talked about Fanconi syndrome. Where's Fanconi syndrome on here?
2.
Where's its? So type 2 proximal. In Fanconi syndrome, what's being lost? Like everything, right? They can't reabsorb.
Bicarb?
So their urine's going to have protein and bicarb and amino acids and lipids. They're spilling everything. Right? We've talked about ACEs and ARBs in the treatment of proteinuria. We've also talked about possible complications from ACEs and ARBs being given to patients with renal disease. Keep those in mind. What's highlighted on this slide?
Independent.
Remembering this is probably going to be useful. Remember the risk stratification for microhematuria. You'll probably see one question where you'll be expected to know the risk stratification and possibly know what to do with that patient. Any questions on this? I promise you that any clinical scenarios that you see from me are not going to be equivocal. Meaning you're not gonna look at the information that's provided to you and have it be, like, for example, just the person turns 40 like next week. Like it's not going to be the parameters that you're given will be squarely within a range that you need to know. And I'm not just talking about for microhematuria, I'm talking about in general. You won't have any equivocal findings. The caveat to that is, remember what I said before about compensation in acid-base disorders. Because that's not equivocal, that's compensation. Review rhabdo. What causes rhabdomyolysis?
Breakdown.
So it's muscle breakdown, but what events can trigger muscle breakdown?
Trauma, infectious.
So trauma. Most people, when they think of rhabdomyolysis, they think of
Marathon runners.
marathon runners or other types of very rigorous physical exertion or obvious trauma. But does it have to be obvious trauma? So somebody doesn't necessarily have to have been in a car accident or had something extremely heavy land on top of them. Can your own body weight cause rhabdo? Can. If you deprive a part of the body of blood supply long enough, even if it's by something that's no heavier than your own body weight, you potentially can develop rhabdo. Be able to differentiate between these conditions? This chart might be helpful. Any questions about AKI? Know your casts. Know your BA and creatinine ratios. Fractional excretion of sodium. You will not see any questions on the exam that presents you with a micrograph and says, what is this? Okay? In fact, I don't have any clinical images on the exam. None. You'll have charts with lab values, but there's not going to be any pictures that says, what is this? So let's back up to the previous example that we were talking about before with white blood cell casts. You're not going to see any questions that says, patient comes in, febrile, flank pain, nausea, vomiting, microscopy reveals this. What is it? And it's not. You're not going to see any questions like that. If there's a cast that I want you to be thinking about, the question's going to say they have X casts under your analysis. It's going to tell you. Okay? So don't worry about looking at micrographs and saying, okay, well, that's what a muddy brown cast looks like. That's what a Highland cast looks like. You're not going to be asked to identify those things. Rhabdo. We've already mentioned this, but here's another condition that can cause white blood cell casts. It also causes a skin rash. Maybe you remember that. I think I mentioned yesterday to remember that medications can cause interstitial nephritis. Keep that in mind. All right, be able to differentiate between your nephritic and nephrotic syndromes. when I say that, I don't just mean know that, well, this is nephritic and that's nephrotic. I mean, be able to differentiate between the nephritic syndromes, differentiate between them and the nephrotic syndromes. Are you likely to see minimal change disease in a 50-year-old? No. So that's another equivocal type question you're not going to see from me. I'm not going to give you a condition that's most commonly seen in children and pull that one random scenario out where it can show up in an adult. Pediatric conditions will be pediatric, adult conditions will be adult. There's no gotchas like that, okay? Remember the latency periods. Knowing the latency periods for various conditions will be helpful. And know your lab titers. Any questions about that? So renovascular hypertension. What are the two most common causes of renovascular hypertension? Two broad categories of conditions. Not what causes them. I mean, not medical disease. Yes, medical disease will beget what I'm thinking of. So atherosclerotic vascular disease is one of them. What's the other one? Fibromuscular dysplasia. Yeah. What does fibromuscular dysplasia look like on imaging? Beads on a string of pearls. Again, be able to differentiate between interstitial nephritis, post-infectious glomerulonephritis, acute tubular necrosis. What's the big difference between, say, autosomal dominant polycystic kidney disease and autosomal recessive polycystic kidney disease? Size. Nephroblastoma. Can it happen in adults? Am I going to ask you a question about nephroblastoma in an adult? No. What are some significant exam findings in nephroblastoma?
Distended abdomen.
I saw you do a hand motion. What was your hand motion indicating? Mass doesn't cross the midline. Already mentioned this, atherosclerotic vascular disease versus fibromuscular dysplasia. What else are you likely to see in a presentation of a patient with fibromuscular dysplasia causing renal hypertension?
Refractory to medication.
From a therapeutic standpoint.
Refractory to medication.
Refractory to medication. Multi-drug treatment with no results as far as their hypertension is concerned. Any questions on renal artery stenosis, and renal vascular hypertension. It might be a good idea to remember the new kids on the block when it comes to treatment of kidney disease in a diabetic patient. So I'm not going to give you a name of a medication and expect you to know what class it's in. It'll just be a class of medications. Unless it's something really straightforward, like if you see metformin, you know what metformin is, right? I'm not going to ask you to remember the names of all the SGLT2s and the GLPs. Right? It'll just be a broad category. Okay. But for the medications that are older and more common use, like verapamil. What is verapamil?
Calcium channel blocker.
Louder?
Calcium channel blocker.
Yes. Okay. Calcium channel blocker. What about lisinopril?
ACE.
Right. It's an ACE inhibitor. Okay. So if it's a medication that is old, it's been around for a while, it's in common use, then you may see the name of the medication, the actual name of the medication. But if it's an SGLT2 or GLP-1, it's just going to say SGLT2 or GLP-1. You don't have to remember which is which, what's what. Okay. All right, there's your nephroblastoma again. Pediatric condition, mostly, rarely crosses the midline. Remember that. Patients with medullary sponge kidney usually have degradation in the renal function?
No.
Usually not. Not simply by virtue of having medullary sponge kidney. Obviously, all of these conditions that we've talked about over this block can potentially end up resulting in degradation of renal function. But medullary sponge kidney, in and of itself, does not usually result in loss of renal function. Minimal change disease. Minimal, small children. It's a nephrotic syndrome. How do we treat minimal change disease? Steroids. Are there other conditions that we've talked about where steroids are not indicated? Yep. But it is indicated in this one. What's a significant clinical sign or symptom for Goodpastures?
Anti-GBM antibodies.
So that's a laboratory finding, not a clinical presentation.
Dragon. Pulmonary infiltrates.
So not the X-ray, but I think I heard somebody say it. Right, hemoptysis. So be able to differentiate between the different glomerulonephritic syndromes. Clinical history, presentation, those things will be useful. questions about that? Remember, this condition is potentially precipitous. Moves fast. Gotta get a handle on it quickly. Okay. If you see a patient with Henoch-Schönlein purpura, if they're not super sick, how are you going to manage them? Is this done in the hospital or at home?
At home.
At home.
Control hypertension and other symptoms.
Remember this. Remember that polycystic kidney diseases can have extrarenal manifestations potentially. Think of beating the renal artery, stenosis, and revascular hypertension and death. Know the ins and outs of that condition. Know what your imaging modalities are for this. Questions on that? Yeah.
Since the renal arteriography is a gold standard, would we still do a CT angio first?
There will be no gotchas on the exam. I'm not going to give you a question that has more than one option that are plausible. The right answer is going to be the right answer. Okay. So, using this as an example, if your options are CT angiography, plain film X-ray, nuclear medicine study, and I don't know, Ouija board, which one are you going to pick? Right.
I don't know the
Okay. You're not going to see a question that has renal arteriography and CT angiography as choices. Okay, I don't play that game. Because depending on where you're at, I mean, they're both perfectly acceptable studies for evaluating for renal artery stenosis. They are. But if you're not at a med cen, you're probably not going to have the ability to do renal arteriography. The right answer will be the right answer. All right, so the rest of the slide deck is just questions. I can go through them with you. You can review them on your own time. It is entirely up to you. We can be done now, or we can do questions. So you gonna do some questions?
Yeah.
Okay. Say again? Yeah. Let's take a quick break. Everybody go use the toilet if you need to. Okay. What do you think?
Waxy?
Waxy casts. Okay. When you hear the term or read the term urinary stasis, that doesn't necessarily mean urinary stasis in the bladder because they're in retention. First of all, we're not in the urology block, right? We're in the nephrology block. So urinary stasis in terms of a slower filtration rate through the tubules is potentially going to result in the formation of waxy casts. Also, are any of the rest of these correct for urinary stasis? Whether it's upper tract stasis or lower tract stasis. Now, if it said, which of the following is an indicator of urinary stasis that results in a kidney infection, which one might be the right answer? White cell casts. But that's not what it says.
White cell's not an answer.
Everybody knows what the right answer to this is, right?
Hey.
Okay. What do you think?
Delta?
Delta. So can somebody have an increase in their BUN from something other than intrinsic renal disease? Can somebody have an increase in their BUN creatinine ratio from something other than intrinsic renal disease? Does intrinsic renal disease cause squamous cells in the urinary sediment? No. What is TAM-Horsfall mucoprotein?
It sounds real.
Also referred to as uromodulin. Remember at the very beginning of this block we talked about the fact that you can have detectable protein in urine, and that doesn't necessarily mean that there's something abnormal going on. Up to 150 milligrams per day of protein on a 24-hour urine collection is normal, and the most predominant constituent that results in that is TAM-Horsfall mucoprotein or uromodulin, same thing. And it's actually protective. It helps prevent stone formation, among other things. So the only one of these that is most closely associated with intrinsic renal disease is an increase in serum creatinine. The key phrase there being most closely. Because some of these are just flat out wrong, and the other ones can be associated with other things besides, and in fact may even be more closely associated with a different problem than intrinsic renal disease. What's the right answer?
Delta?
Delta. Do you see renal arteriography on here anywhere? No. Do you see MR urography on here anywhere? Or MR angiography? Are any of these studies going to look at the structure of the vasculature besides CT angiography?
No.
No.
Delta?
Only one of them is an ineffective osmol.
Delta?
Not delta,
Oh, no.
urea. Urea is an ineffective osmol. So know the difference between effective osmoles, ineffective osmoles. Effective and ineffective are not synonymous with measurable and not measurable. Okay? So know the difference.
Sodium?
Sodium. Not readily permeable across the cell membrane.
In the city? Charlie?
Tonicity. Remember, osmolarity and osmolality are measures either by weight or volume. But the pressure gradient is the tonicity.
Glucose.
Glucose. Everybody understand why that is? Anybody not understand why that is? So her sodium's low, but her osmolality is high. Which one of these things is going to have an impact on osmolality?
Glucose or mannitol?
And while it doesn't tell you that she's diabetic, it doesn't tell you that she's not been taking her medication as indicated, the only one of these things that should be elevated in this presentation is glucose. What's the bicarb likely to be?
Low?
Low. Because she's probably acidotic. Louder?
Delta?
Delta, urine sodium. Also true for hypervolemic, hypotonic, hypertension. Both directions.
Delta? Delta?
Delta. That means it's sickness.
So the enzyme called hypo or but it doesn't say that there's it's high sodium, high alkaline, you're choosing hypovolemic.
Nope, not C.
B then?
Not delta.
Bravo?
Bravo. So this is where remembering your fractional excretion of sodium values are helpful. Like pre-renal versus post-renal. yes, the patient has signs of congestive heart failure, but based on the FENA, advanced renal disease is the cause. So remember, ticks and fleas, you can have more than one condition, and figuring out which one is which one's causing what problem is all part of the fun of medicine, right?
Charlie?
Delta?
Delta. Think about it. Which one of these doesn't show up on a metabolic panel? Ammonium chloride. A. Pretty straightforward, right?
Is it the diarrhea?
Not the diarrhea.
Dang it.
What is normal saline? Sodium chloride. So you're giving in sodium and chloride. In which one of these conditions are you losing sodium and chloride?
Hyperaldosteronism.
Probably probably.
C.
Damn.
So what are the constituents of gastric fluid?
Put it like that.
So normal saline might be given for multiples of these, but the only one that you're only going to give normal saline for to correct the problem is going to be nasogastric suction. It's E, right? E. Bravo, type 1. Nephrolithiasis is only associated with RTA type 1. All right, this isn't a question, just a reminder. These are your normal values, and the exam questions themselves will provide you with normal values anywhere that lab findings are provided. Okay. Remember, there's a difference between arterial pH and venous pH. Okay. So no, and again, there's no gotchas on the test. I'm just saying, remember, know what lab value you're looking at. If you're evaluating a patient in real life and you're looking at their pH and it doesn't look quite right to you, was it an ABG or was it a VBG? Just remember that. And let me know if I need to flip back over to the normal values at the grip thickness.
Alpha.
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 Metabolic acidosis. So we know the patient's acidotic, right? pH 7.06. And the bicarb is what?
30. Or 17. Sorry.
17.
What was it?
So remember the chart with the arrows. Okay. Was the patient breathing at a normal rate before intubation? They're tachypnic, right? So what happens when somebody's tachypnic? They're blowing off CO2. So if your normal CO2 range is 35 to 45, and here it's 30, the reason it's low is because they were compensating. Charlie. So, again, they're acidotic, right, low pH. What's their PaCO2?
Super high.
And then what's their bicarb?
Relatively high.
So that's compensatory, right?
Echo.
E. Why is it E? So she's acidotic,
CO2 is low by
and her PaCO2 is low, so we know it's not respiratory. I mean, D's got to be wrong because that's not what the question's asking, right? Most appropriate proteinuria screening test for a newly diagnosed diabetic. Most appropriate, newly diagnosed. I think I heard somebody say it. Louder. I was a field artilleryman, remember? You got to get over the tinnitus.
Delta?
Not D. Bravo. So are you gonna submit someone to a 24-hour urine collection if you don't know that they need to go through the pain of a 24-hour urine collection?
Yeah.
Yes.
Screw that.
Army, military, pain. Yeah, no. So if you go back and look at the hematuria proteinuria slide deck, there is a slide that talks about the urine creatinine ratio, excuse me, as being a good surrogate, right? So if their urine albumin creatinine ratio is off, then you might say, okay, we need to do a 24-hour urine collection for proteinuria. Okay. But urine protein creatinine ratio doesn't tell you what you really want to know, because what you're most concerned about is not their protein. You want to know something specific, not all protein. You want to know albumin, because albuminuria is what?
Bad.
Bad.
High mortality.
It's an independent indicator of an increased risk of all-cause mortality and morbidity. Right. So urine albumin creatinine ratio, a dipstick urinalysis. I mean, that's just gonna, if there's protein present, again, it's just gonna be positive. It's not gonna tell you from what. 24-hour urine collection, too much of a pain if you don't know that you actually need to do it. And urine protein electrophoresis, expensive, send out, and most likely going to follow an abnormal 24-hour urine collection. Okay, so urine albumin creatinine ratio. Is it orthostatic?
No.
Is it glomerular?
No.
No.
Is it tubular?
Yes.
No.
Oh, no. That's right.
Is it overload? No. It's functional. Strenuous exercise. Functional. What even is overload proteinuria? It's not a thing. Delta. Why is it delta?
Confirmatory of the initial. It's confirmatory of the initial UA.
Right. So you want to make sure it's actually blood, because there are other things that can cause a dipstick to be positive for hematuria besides blood. Bravo. Remember, pre-renal means that it's a problem before the kidney. Something is going on with them that is occurring before the kidney. And only one of these happens before the kidney.
You have a pre-renal
So
obstruction.
either because they are septic, or their volume down because of the trauma. So something is causing decreased perfusion of the kidney. And then you're going to say, okay, well, what about renal artery stenosis? Well, is the renal artery before the kidney or after the kidney? It goes to the kidney, but is it before the kidney or after the kidney?
Before?
It's before, so it's pre-renal. Okay? So even if the reason for their hypoperfusion is the fact that their renal artery is stenotic and they're not getting enough blood supply, it's still a pre-renal problem.
C.
See.
I think C is more specific.
Congratulations.
I put pyelonephritis on there. Messed up.
Echo.
Actually,
So pyelonephritis or acute interstitial nephritis. If it's acute interstitial nephritis, what kind of white blood cell cast is it going to be? I mean, what kind of white cells will make up that cast?
leukocytes? Or not? Oh no, I was thinking of pilot.
Eosinophils.
Eosinophils.
And do remember that there's a rash associated with acute interstitial nephritis. How many conditions have we talked about during this block that have a rash associated with them?
Just this.
2.
Oh,
What's the other one?
no.
Peanut Schonlein purpura. Note what's highlighted on the slide. Might be helpful.
Taking that one to the big room.
Delta? D?
Delta. Yeah. So nephrotic spectrum diseases, they all have proteinuria, right, greater than 3.5 grams per day. They all have lipiduria, which shows up as what?
Triglycerides? High triglycerides?
What have we talked about on microscopy? So they're both listed here, but so I mean they're both correct. Yes, they have lipiduria, and then if you look at the casts under polarized light microscopy, you see oval fat bodies, and then marked edema because of the
Protein.
proteinuria causing a change in their oncotic pressure, but not red blood cell casts. Can someone with a nephrotic syndrome have red blood cell casts?
Yes.
Yes, if they've got something else going on, right? Takes and please. But again, no gotchas. So the only one of these that doesn't make sense is RBC casts.
A?
A. IgA nephropathy, concurrent, or within a day or two. Again, I'm not going to give you equivocal time frames. Any question that asks you to identify an underlying cause based on time of presentation, it's going to be squarely within the ranges that we talked about in class. Okay, so for IgA nephropathy, it's either going to be concurrent with or within 1 to 2 days following resolution. So I'm not going to give you a question that says day 3, because what's the other time frame that we talked about that was close to this? 7 to 10. So I'm not going to give you 3 days, 4 days, 5 days. It's either going to be same time or within a day or two, or it's going to be greater than a week. Okay. D. Why?
Blood.
Nephritic syndromes are associated with hematuria. Ascites, is that associated with a nephritic syndrome?
No. Nephrotic.
Nephrotic syndromes have ascites. What causes frothy urine?
Protein.
Protein. Pneumonia is not a common presenting symptom of nephritic spectrum diseases. Are there pulmonary manifestations that you can see in some of the renal inflammatory conditions?
Yeah.
Absolutely, but is it pneumonia?
No.
No. And then, is stupor a common presenting symptom? No. So, dark color urine. C. Anti-streptolysin.
I just remember from this chart he gave us.
So, the key thing in the stem here is in confirming, not differentiating between. Only one of these confirms post-infectious glomerulonephritis. Complement levels might help you differentiate between two conditions, but the only one that's going to tell you for sure that it's post-infectious glomerulonephritis of these choices is an ASO titer. We only talked about plasmapheresis for one condition. A, Goodpasture syndrome. We talked about this a lot. Thrombosis. Why thrombosis?
Blood gets thick. Platelets are rubbing against each other.
So increased viscosity of the serum, okay, results in, we'll call it hematologic stasis, which increases the risk of thrombosis. Does having a serum albumin below 2 increase a person's risk of having a nephrotic syndrome? No. Having a nephrotic syndrome can cause your serum albumin to be below 2. But let's say somebody's serum albumin is below 2 because they're old and frail and haven't been eating. Does that mean they're going to develop a nephrotic syndrome? No. No. Failure to thrive does not cause nephrotic syndrome. Does having a serum albumin below 2 increase your risk of developing glomerulosclerosis? No. And does having a serum albumin below 2 increase your risk of developing purpura? No.
Delta?
Delta, hydronephrosis. So both a defect in outflow of urine from the kidney can cause hydronephrosis, as well as back pressure from urine being pushed back up from the bladder in the case of a child with vesicoureal reflux. Also, forgot to mention this, just as an aside, again, not on the test, but something to think about. We've talked a lot about renal transplantation. So what did I tell you prevents reflux of urine up the ureters? What is it that actually prevents reflux from happening? So it's not really a flap, but it is a functional valve mechanism, right? Because the ureter travels through the detrusor through the intramural tunnel, as opposed to it just coming in and plugging it at a 90-degree angle and just opening straight into the bladder. Where does the transplant ureter go? Does a transplant ureter go through an intramural tunnel?
No.
Could you build one? You could. You could. Is it necessary? No. And because of where the transplant kidney is placed, in order for it to reach the vasculature, the anastomosis of the ureter to the bladder is generally somewhere near the dome. So you're just plugging it straight in. You make a cystotomy, you spatulate the ureter, and then you sew it in. And so, do you think people with renal transplants have some degree of hydro in their transplant kidney? Yes, normal finding. Only one of these is correct.
Delta.
Not delta. A. Why is it A? So we've already established that the patient has renovascular hypertension. It's in the stem. How are we going to, of these items, which one is going to help us differentiate between the potential etiologies? What are the two main etiologies of renovascular hypertension? Atherosclerosis and fibromuscular dysplasia. Does hyperlipidemia predispose someone to fibromuscular dysplasia?
No.
Nope. But does hyperlipidemia predispose somebody to atherosclerotic vascular disease?
Yes.
Yes. Okay. Age. Can somebody have atherosclerotic vessel disease at a younger end of the spectrum?
Yes.
Sure. What if somebody has congenital hypertriglyceridemia? The severity of a hypertension, that doesn't tell you which one it is. They can both be equally as bad. And response to antihypertensive medication isn't going to tell you the difference necessarily, because you can have multi-drug resistant hypertension in atherosclerotic renovascular disease. Now, the classic presentation for somebody with fibromuscular dysplasia is someone on 4 antihypertensive agents, but you can have somebody with atherosclerotic renovascular disease who's on multi-drug refractory antihypertensives as well. So the only one of these that's going to help you potentially differentiate between the two of the options listed is hyperlipidemia. Flag vein. Common presenting system for both, a symptom for both. So if they've infarcted their kidney, either in part or in whole, that hurts. Oh, real quick, we'll talk about this a little bit more in the urology block, but where are the sensory nerve endings in the kidney? Where are the nerve endings that cause you to feel renal colic?
Thoracic.
Say again?
The thoracic spine?
So not where do they come off from? Where are they located in the kidney? Where are the sensory nerve endings in the kidney? Are they in the cortex? Are they in the medulla? Are they in the renal sinus fat? None of the above. The sensory nerve endings in the kidney are in the capsule. They're all on the outside. So something has to affect the capsule of the kidney in order for there to be pain associated with it. So if you've infarcted the kidney, either entirely or in part, then the capsule that overlies either the entire kidney or the part that's been infarcted is going to have some effect on those nerve endings. This is why non-obstructing kidney stones are asymptomatic. If you've got a stone that's just rolling around in the kidney, not blocking anything, there's no sensory nerve endings in the renal pelvis. Just having the stone there doesn't do anything. It has to obstruct the flow of urine, which causes a buildup of urine, right? Increases pressure, which causes the kidney to stretch. Which is also why the pain goes away when the stone either makes its way further down the ureter and urine's able to drain around it and the pressure's relieved, and then starts to build up again. That's why the classic presentation of renal colic for nephrolithiasis is it comes in waves and it builds slowly because it's a function of the pressure building slowly behind the obstructing stone. Okay, but the sensory nerve endings in the kidney are in the capsule. C. Single, simple renal cyst. Congratulations. Incidental finding. Nothing to do with that. B. Again, the key here is initial. Ultrasound is very effective for evaluating the parenchyma of the kidney. It's really good at looking at cysts. It's inexpensive. There's no ionizing radiation. It's non-invasive. Did we even talk about captopril renography? It's a real thing, but we didn't talk about it. E, it's definitely E. It's for sure E. I mean, they might as well have a little bit of joy in their life, right?
Pain will go away.
Yeah. Okay. What is losartan? It's an ARB. ARB, diuretic. NSAID, wrong, don't do that. Beta blocker. ARB. Medullary sponge kidney is usually asymptomatic, right? Usually asymptomatic, usually doesn't have any untoward effect on renal function. So how does somebody find out they've got medullary sponge kidney? D. They get a stone. Medullary sponge kidney is at increased risk of forming kidney stones. And none of the other things. Now, can you get an obstructive uropathy from a stone? You can, but you have to have the stone first. And by definition, obstructive uropathy is a condition that occurs as a result of an obstruction. So just having an obstruction, that isn't obstructive uropathy. That's an obstruction. Obstructive uropathy is dysfunction as a result of obstruction. So if you have an old male patient with BPH and they've had it for years and years and years, and they don't empty their bladder well, and they've got degradation in their renal function that's due to that obstruction, that's obstructive uropathy. E.
It's always smoking.
Yeah. It's always smoking.
Unless it's not.
Except when it's not. But yes, yeah, tobacco exposure. How old is the patient?
59.
So not a kid, right?
Process
A. Membranous nephropathy. So, coarse crackles, pitting edema, 4+ protein in the urine tells you it's probably what type of syndrome? It's a nephrotic syndrome. Which of these are nephrotic syndromes?
Membranous nephropathy.
A and C. The patient is 59. So it's not going to be minimal change disease. And membranous nephropathy is the most common cause of nephrotic syndrome in patients that are non-diabetic. And there's nothing in this stem that would indicate to you that the patient's diabetic. Okay. Here's the slide from the slide deck. Membranous nephropathy, most common cause of primary nephrotic syndrome results. What do you think? Okay. Post-infectious glomerulonephritis. Pharyngitis, how long ago? 2 weeks.
D.
It's definitely not reassure the patient and monitor. And why would you order a renal ultrasound? You already did an MRI. Is the ultrasound going to tell you more? No. And why is this wrong? Why is E wrong?
Because we don't care when she has cancer.
So there's a reason that E is wrong other than I told you don't do cytology. There's another reason that E is wrong.
Because if it can metastasize the cancer potentially.
Nope. So urinary sediment cytology, so you're talking about avoided urine cytology, not a biopsy. The reason E is wrong is, so it's a 7-centimeter mass in the upper pole of the right kidney. What is it probably? What kind of cancer? Renal cell carcinoma. Is ordering a urine cytology part of any workup for renal cell carcinoma? No. Urothelial carcinoma, yes, but not renal cell carcinoma. So that's why that's wrong. Also, don't do it. Louder.
D?
Not D.
Delta.
D. Hyponatremia.
He might have cancer.
He's an alcoholic. He's got ascites, pitting edema. So is he volume up, volume down, euvolemic?
Volume up.
You don't know. That's kind of a trick. The information you provided doesn't really tell you whether or not it is volume up, because you can be volume up and have edema,
Can you have a
but you can be volume down, you can be euvolemic, and if the fluid's just in the wrong place, then you can have edema and ascites. But what is the most common electrolyte abnormality in a chronic alcoholic?
Hyponatremia.
Hyponatremia. Now you would assume, based on his presentation, that he's hypervolemic. It's probably cirrhotic. So, but hyponatremia. Last question. A. So,
I don't want to deal with that.
stage 4 kidney disease, lethargic, he's got systemic symptoms, potentially CNS symptoms, and his GFR is 7. He needs dialysis. Questions about that? Questions about anything else? Okay. If you have questions over the course of the next week as you're preparing for the exam, please come see me. My cell phone number is on the landing page for the GU block. If you want to find out if I'm in my office before you walk over there, just shoot me a text. Let me know who you are. Identify yourself, because I get lots of spam text messages from random numbers. So let me know who you are, and I'm not kidding. I have had like spam text messages that say things like, "Are you in your office?" So if the person doesn't identify themselves, I ignore it. I ignore it and I block it. So yeah, if you want to come talk to me about anything, if you got questions, just text, make sure I'm there. Otherwise, if it's not super time sensitive, you're certainly welcome to email me as well at my army.mil, which is also on the landing page, which I would appreciate. You guys are going to do fine. But yeah, good luck. And enjoy your 4-day.
I did not see
All these blocks are so quick.
it's covered. No, I know.
On the bright side, we don't have any more like weakness.
I never used to try to but kids sometimes walk in and like, hey, well, study this section right now.
Cody, you could take the test today and probably get an A.
Fuck no.
Listen to you.
I was doing it last night, so I checked a couple of them, but I got quite a few. I was like, I think it's this. I'm not sure.
Yeah.
Well, benefit.
We got there. We got there. We got there. Nicely done, eh? Nicely done. Let's go.
Try not to get hypothermia in the classroom.
Yeah, this is just banana.